I would now like to introduce Anshu Choudhury from the Blue Cross Blue Shield Association to introduce our next panel.
Thank you, Sarah, and thank you all for joining today. I'd like to thank the Alliance and Sarah and her team on bringing us together for today's discussion, Navigating the Frontiers of Innovation and Value. The Blue Cross Blue Shield Association is a proud sponsor of today's event. As a significant stakeholder in nearly every healthcare market nationwide, we share the goals of everybody in this room of improving our healthcare delivery system and the way that the healthcare system interacts with patients across the country. As we all know, the healthcare industry is undergoing unprecedented change with the implementation of the Affordable Care Act, expansion of retail healthcare, and the rise of consumerism, new provider payment models, and rapid change in medical technology and the delivery of care. But for innovation to really fulfill its potential, it's going to require partnerships like the ones that you'll hear about today. Public and private sector partnerships, partnerships where doctors, hospitals, health plans, manufacturers, where various stakeholders, often with competing interests, come together to break down silos for the good of the patient. That's the approach that Blue Cross Blue Shield companies have taken in their local communities, seeking out partnerships to help ensure that our 107 million members across the country receive safe, high quality, coordinated, and effective care. But all the innovation in the world is not helpful if it doesn't ultimately reach the patient, whether it's because of cost, whether it's because of access, or the solution just wasn't designed with the end user in mind. So if we are going to give the patient a voice and give them a role in policy decisions and how healthcare is delivered, how do we do it in a way that's sustainable and not just a one-off conversation? Fortunately, our next panel has this all figured out and is going to share that with you. So it's my pleasure to introduce Jennifer Bright, who will be moderating the next panel on the value of the patient voice. Jennifer is the president of Momentum Health Strategies, where she works on advancing patient engagement, researching care and delivery, primary and behavioral healthcare integration, and prevention strategies. So please join me in welcoming Jennifer Bright.
Well, thank you very much to the Alliance for Health Policy for inviting me to talk about one of my favorite topics. As my introduction was made, I actually have worked for the last 25 years in this space, starting out as a mental health advocate, patient advocate. So this is a very near and dear topic to my heart. So I'm joined today by a terrific panel that's going to bring a variety of perspectives to this. But before I introduce them, I just want to say that Dr. McClellan's setup could not have been more perfect, and I didn't pay him to set it up that way. But if you did a précis of his presentation, basically what he told us is that value is really a multifactorial concept. It has inputs from a whole different angles, perspectives, which you're going to hear about on our panel today. It's first and foremost patient-centered. It's grounded in outcomes-driven results, and it's about optimizing both clinical and social care. And if you have all of those ingredients, what you get at the end is cost and effective care. And so I think it's perfect the way he set it up, because our job today is to talk about the value of the patient voice. And so patients first, that's my advocacy hat coming out. So today we're going to hear briefly some remarks from several of our panelists, including Lisa Feng, who is here representing the Cystic Fibrosis Foundation, Susan dosReis, who's going to bring the research perspective in her work at the School of Pharmacy at University of Maryland. We're going to hear from Josh Seidman, who brings a lot of experience working with industry and payer, but also has led some significant work in value assessment and how it impacts shared decision-making. So I'm looking forward to hearing those perspectives. And finally, Dr. Steinhorn, who brings more of the clinical side perspective. So I think you're going to get a 360 view. And to kick us off, I'm going to start with Lisa. And I just ask each of our panelists to add any detail you'd like to as far as your introduction. But most importantly, I think we're not talking about today whether the patient voice has value. I think we've spent the last 20 years talking about that. What we want to get to is how. How is the patient voice impactful from your perspective as a patient advocate, as a researcher, what have you? And then we'll get into how we make that happen in a better way to achieve value. So Lisa, please.
Great. Well, thanks, Jennifer, and thanks for having me here today to talk about the cystic fibrosis community. Before I go into the work of the community and the CF Foundation, I wonder if I can just spend a minute explaining CF. So cystic fibrosis is a genetic disease affecting about 35,000 people in the US. The gene mutations lead to defects in a protein that causes sticky mucus to build up in almost every major organ in the body. So affecting the pulmonary system and the lungs and the airways, the GI system, the pancreas, and in many cases, the endocrine system, as many people with CF develop cystic fibrosis-related diabetes. So since I think the Middle Ages, CF has been known as a pediatric disease. And that is unfortunately because very often children don't live to adulthood. It's a very life-threatening disease. And until recent years, that is still largely true. But we're very much in a new era of CF through improvements in care delivery, where we have a multidisciplinary coordinated care team centered in some centers of excellence across the country, and symptomatic treatments that target the specific symptoms of CF, like mucus clearing, infections, and other things. And then most recently, we have precision medicines, so genetically based medicines that target the underlying defect of CF. That have really ushered us into a new era where there's a growing number of adults now. Now, a couple years ago, we've reached a point where there are more adults in the population than children. And so that tells us that people are living longer and healthier lives. And we have a lot to look forward to. So this community is not a stranger to innovation and extremely acquainted to engaging in every aspect of this. And so that means from the research side to care delivery, working with their providers to partner with their care to improve adherence. Obviously, I work in policy and advocacy, so working with us to help us understand what their financial burdens are. What are they experiencing in the healthcare system? On cost, on access, and the drug development side too. So, as I mentioned, we have some new drugs out that are, I think the epitome of, they were now that there's genetic therapies out, but they really exemplify precision medicine. The first one was approved in 2012. And that corrected a defect in the protein that causes CF. It was highly effective, but it only affected about 4% of the population based on their genetic mutations. But just a couple weeks ago, the FDA approved a new drug, Trikafta, that based on its indications can benefit up to 90% of that 35,000 that I just mentioned. So that's huge. And that brings us into a whole new world of what is CF care going to look like? What is the face of the population going to look like moving forward? And the patient community, again, is helping us understand that. And so I'll just give a quick example. So knowing that the treatment landscape is going to change vastly, we asked the community, we surveyed them, and we said, help us prioritize our research. So the foundation is an engine of CF research across the board. And we had some resounding calls for reducing the treatment burden. So you basically, from their perspective, you say that there's these new highly effective drugs coming down the pike. I spend 2 to 3 hours a day with my chest therapy, take 5 to 8 medications a day, 40 to 60 pills a day. This is taking a lot of time for me and my family, a lot of money for me and my family. What can come off? And we're interested in that as well as representatives of the providers community. And so we are working with the community to design and implement a study called Simplify. What can come off from this new regimen? And of course, that's interesting, or it should be, to the healthcare system too, because we're all looking for efficiencies. And if you want to call it cost savings, value, or whatever, I think that from the patient perspective, they're looking to make their lives a little bit easier, to take the burden off. And we're hoping to implement a study that gives us good evidence to do so.
Great, Lisa. Susan, talk to us a little bit about the research perspective. How do you define patient engagement from the research that you do, and can you give an example of where it's been impactful?
Great. Thank you again, Jennifer, for the invitation for this panel to be a part of it. And I have to say, I resonate a lot with the words that Lisa just shared. And from the research community, I think there's a lot of different opinions about what patient engagement means when we take the patient voice. So having somebody participate in a focus group or complete a survey or give patients something to react to that you have developed doesn't necessarily mean you've engaged that community. And so what we've done, and the work that we have undertaken in the past 15 years is really bring that patient on board at the beginning. So we really understand what that burden means. There's the burden that you just explained about the 20 pills per day, the amount of time it takes for a patient to actually engage in therapy, I think is understated when we measure burden in many of the instruments that we have. And so for us, engagement means bringing the patients on board at the beginning. They are part of the research team, and so they help us think through what these concepts mean when they are the ones who are seeking care, what their lived experience is. And how we try to kind of blend that is, and how does that influence how we ask the questions, how we operationalize our instruments to really understand the meaning behind that construct of patient burden, or what would be a good outcome for a patient. I think that is also something that takes a lot of time to really peel back the layers of what patients kind of go through. So I can give you an example of some of the work that we're doing to kind of engage patients is that we have a center at the School of Pharmacy. It's Patient-Driven Values and Healthcare Evaluation, which we have patient stakeholders on our advisory board. And we've worked with them to understand what is it that's important in treatment decision-making from the patient perspective. So certainly side effects are important, certainly burden is important. But we actually delve a little bit deeper to really understand how we can better operationalize that. And we're trying to kind of bring together these concepts and understand where are thresholds for patients with regard to decision making. Some people think, well, if we just go by what the patient says, it's going to cost more because patients want the most costly and the best. And I would argue that that's really not the case. What patients want is something that's going to work for them. And so what are those trade-offs? So we know that there's a cost limit that patients are willing to pay, that everybody has an affordability threshold. And then there's also a limit of how well these treatments will work to resolve the symptoms and to improve outcomes. So how far are patients willing to go to spend for an extra gain in an outcome or an improvement? And really understanding where those thresholds are, knowing that there's not an average patient and knowing that there's not one way to deliver care. And I think that really speaks to what Mark was saying earlier, is that there are important differences and heterogeneous perspectives out there. And so the work that we're trying to do is bring the patients on board so we understand what those lived experiences mean, build our instruments so that we're asking questions that really get at the core issues that patients are struggling with, and then bring together the research that can have hopefully some meaningful impact in understanding differences across patient populations. So that's, I don't know if that answers fully your question, but yeah.
Great. I think often, just to reflect on something you just said, often the complexity of trying to unpack that heterogeneity and the difference in experience is used as a reason to not do it. So that's going to lead me to my question to Josh, which is, you've done a lot of work with industry, with policymakers throughout your career, when we get to this central question, I think those are, from a patient perspective, those are the last bastions. That's the table that they're not yet fully at. What's your reflection about how that's changing a little bit? Do you think there's more recognition that patients need to be at the table in both policy and payer conversations, and how is that happening?
Yeah. I mean, no doubt it has changed a lot over the last, since I started work in shared decision making about 20 years ago, things have changed enormously, and there's a much greater demand for the kinds of tools, the kinds of resources that will help organizations to be able to do that kind of work. I would say that, for the most part, doctors, other members of the clinical team now recognize that that is something that they want to do. They don't have an infrastructure to support that.
Yeah.
And so part of what we have to do in trying to serve those goals is to make the easy thing the right thing, make the right thing the easy thing to do. And I think that's that's an important part of this. I agree with everything that both Lisa and Susan said. I also agree with you that Mark set this up very nicely by sort of framing this need and this movement towards this value-based payment environment. Part of that critical question, though, is what is value through the eyes of the patient, and making sure that we're understanding that. And so the work that we started about 4 years ago at the time of a proliferation of value assessment frameworks was to really try to understand how one would go about assessing value through the patient's eyes. Mm-hmm. And so the work that we did to build a patient perspective value framework had multiple use cases in mind, and certainly for payers and for policymakers, but also for patients, caregivers, clinicians. How can it support shared decision making? But when we developed the framework in collaboration with a whole range of stakeholders, certainly patients and patient advocacy groups being a big part of that, when we were trying to decide how to understand what its impact could be, we not only asked patients, what do you think of the criteria that we use to assess value, but what would you use this for? And it was that insight that we got from, in this case, it was cancer patients, that led us down the road to developing a specific approach to supporting preparing for shared decision making.
Great. Nice tee up for Dr. Steinhorn to talk about that relationship between the clinician and the patient. And certainly, as the clinician, you representing the clinician community, the patient voice is right there in front of you, with you. Can you talk a little bit about how that's evolved, how that's putting perhaps more burden on the clinician dialogue between patient and clinician, and also what are some of the external challenges that are perhaps holding back that conversation from really bringing forward the patient voice?
Well, I think that this question of value through the eyes of the patient is a critical one. Leave aside the fact that I'm primarily a pediatric physician, because I do plenty of work in adult hospice and palliative care as well. And when you have a hospice physician sitting up here in front of you, you'll probably hear things that you don't want to think about or hear about. And then that gets back to the exact crux of the matter, that our society is a death avoidance society, and therefore all of the values that we have are extension of life without a good understanding of how to fill that time that we've created through technology with meaning, with comfort, with things that really get at the heart of what it means to be human, to be alive, and to experience life. And as a healthcare system, I think that we have fallen short ever since the scientific revolution and René Descartes split the soul from the body and left us with a healthcare system that focuses on science in the Western sense of it, technology, etc., and has ignored the needs in parallel of developing a higher, more effective, more nuanced support of the human being. And I'll just leave it as human being. I won't talk about soul or spirit, any of those things. And I think that that's where we have to increase and improve our dialogue with patients and families. Because the note that I made to myself is that actually many of our new technologies, and I've cared for many patients with CAR T cells and advanced organ transplantation, incur extraordinary amounts of suffering. And you know that this is the case in the elderly dying in ICUs on technology, and this is suffering that does not create meaning and only delays, if you will, the ultimate, which is death. And even the advances in many of our diseases, we don't know how long the CF technologies will benefit patients. We don't know if it'll improve fertility in teenagers and young adults with cystic fibrosis and make their lives more full. So it's all kind of a trade-off. And I do want to close by saying I'm not a Luddite. I have 3 patents of my own in medical technology, and I love medical technology. But in the last 15 to 20 years of my practice, I've come to value the support of the human spirit and guiding families through decision-making in terms of using new advanced therapies as a central part to what we have to do. And that's where I think physicians fall short in their advanced understanding of how to bring these technologies in.
I love that we have a beginning of life to end of life perspective on this panel today. It couldn't be more perfect. So just to sum up what we've just heard, patients can bring insight about how to prioritize research. They can help us identify unmet needs, things that are not happening for their health and quality of life. They can help us understand and identify where treatment burden and inefficiency is causing more problems than it's helping. They can help us talk about things like side effects and how we need to improve the technology that's available. They can help us understand what it's really like to live in one or more disease states and how patients also don't want to be defined by their disease necessarily. And they can debunk the notion, to your point, debunk the notion that more is better, and also clarify what goals look like for both life and health, quality of life, end of life, all of those things. So I think you've hit the gamut. So the question then is, if we know so much and we think that patients can bring all these things, why are patients not driving this conversation? What is stopping us in your mind? And then I want to open it up to questions from the audience. But what in your mind is the barrier to us really achieving this full potential of what patients can bring forward? Because everything you've said is powerful stuff, but somehow it's not driving the engine. Thoughts? You don't each have to answer, just any. Susan.
I think Mark touched upon it in his opening remarks with where we are in our system, in our healthcare system, and so patients haven't been put in this role to be the thought leaders in how we should be doing this, and we don't really have a lot of experience. If you say back 10 years of really putting patients in the role of help us think through these very difficult issues. And so there's a patient education component that I think has to happen in terms of what is value. I think some of the more established advocacy groups, the national advocacy groups, are far more advanced in terms of thinking about this and understanding how value really translates into access to treatments. But some of the other patient groups are not really quite there. And so part of what we're doing with the PAVE Center is building an education component that will allow patients to understand, and often individuals living with conditions versus patients, to your point, don't like to be classified as by their illness, but how these things are important in our healthcare system and how that drives what your provider is able to give you, what your insurance will pay for, And then they become more activated in how they actually come to the table and voice that opinion in what matters. The other thing is we haven't really engaged them in the research, and colleagues in the UK have been more advanced in doing this, where if you think about, I guess from the research world, how can we engage a patient in a population level analysis, this large claims database? I mean, it's a very rough transition from kind of where you are to thinking about these, but when we think about how we interpret data, when we think about how we should be defining these key variables that we are then saying this is a meaningful outcome or not, we could have patients at the table to really think through some of that and understanding why we see that people are engaged in care and all of a sudden they drop off of care. Why are data missing in large parts? And oftentimes we can't explain that, and we have to just explain that away as missing data. And so there are ways that patients, I think, can come to the table, but I think that has to be a bit of educational piece on both sides, from the research as well as from the patient community, of how those two can come together. And I think slowly we're getting there as more groups are bringing patients to the table in helping to drive the research, but I think that might be one of the many barriers.
Yeah.
That we have.
Lisa, and then Dr.
I
Steinhorn.
agree. Education is key, but that gets to, there's a power dynamic. And there just is. And it's how our society is set up, that we revere doctors. We are intimidated by science. And it's not their jobs. So it's looking at patients as people, as partners, is really a paradigm shift to the work of many of us. And so educating them to get them up to speed and to be really crisp about what do you want from them. It's not just a token, oh, I invited a person with this disease to my meeting, and so now I'm patient-centered. It's not that. And it's really hard. I mean, even though I work at a patient advocacy organization, everything that we do, we try to integrate people with CF in it, but it's still hard, and we're still feeling our way into it. So, for example, we have been integrating people with CF and family members, so for the parents who take care of their kids, in our committees that develop clinical guidelines. So these are rigorous committees that eventually put out peer-reviewed guidelines. And now we have some community representation, and there was a survey among the physicians who were involved in the guidelines. And the question was, did the involvement of the patient community add value to how we develop these guidelines? And 50% said yes. And when I first heard that, I thought, oh, that's great. 50% said yes.
50%.
But then 50% said no, so whatever. And so, how can we still have a lot to kind of create and innovate in this area of how do we really get meaningful interactions between researchers, clinicians, and patients, and really people on the other side.
Dr. Steinhorn, did you?
Yeah, I think that there's a huge philosophical problem here in terms of the interface between society and the healthcare system. And, I'm quite anecdotally, my son is an internal medicine resident at Mass General Hospital, pretty bright guy, very compassionate and warm, but he's throwing the towel in on internal medicine because he says, I go to my outpatient clinics, I have all these obese, hypertensive patients with type 2 diabetes, and they won't follow the instructions I give them. So what is the point of doing this? He's going into anesthesiology, which is a great fit for him. But the bottom line is, I think that the pendulum of shared decision making swinging so far in the direction of patient and family autonomy, That's great from an ethical and philosophical point of view. It has, however, eviscerated the authority, not the authoritativeness, but the authority, the knowledge and the wisdom that people with 10, 15, 20 years of dedicated experience and training in healthcare have to help families make decisions. And it's empowered families to ask for more and more and more. And I'm not talking about asking for, let's try a CAR T cell because the bone marrow transplant failed and I need to get some advanced technology. Well, let's have a second or a third liver transplant because this one is not working or because the patient started drinking again, whatever it may be. I think that we saw the level 2 reimbursement schemes that Dr. McClellan had up there being incentives for physicians to provide better quality care. On the other hand, where is the incentive for the patients to be more responsible and care for themselves? Because we're talking about partnerships between patients and the healthcare system. And I think without ownership and responsibility for one's own health care, that it is very difficult for the healthcare system to come up with a new pill, a new gene therapy, a new whatever it may be to alleviate the problems that patients have. Because in the end, death is there for all of us, and it's only a matter of how we get there and what we do with the time. It's not a heavy thing, but we don't normally talk about that in social situations. And so in this whole dialogue, families and patients have to accept the fact that they have a certain responsibility and ownership if they want to be partners and share in decision making with the healthcare system, because we can't do it all for them.
Josh, did you have?
So, I mean, what I was going to say before was that, I think it gets back to something Susan said earlier, that, if we are going to be trying to support patients, we have to start by asking them, and we have to bring them in from the beginning. We can't assume that if we sort of develop something and then sort of get their opinion afterwards that we're going to be designing something that's going to support their needs. So we need to start that way, and I think the idea is that it would be the same, I think in terms of, getting back to what you were saying, we do need to design shared decision making that supports the ability of each party to provide what is desired and necessary. So the reality is that when I talk to patients most of the time, they do tell me that they want support and guidance from their experts, their clinicians, and others. But that should be understood in the context of what are their goals, their values, their needs, their preferences. And so we need to create systems that do that. And so we really need to take a human-centered design approach to designing for both the patient and the clinician to support the kind of environment that will allow that to happen.
Great. Let's take a few questions from the audience to stimulate some more discussion. I think there are microphones, perhaps. We have a gentleman here in the middle.
Strong voice, so I'll just use my voice.
Hi.
I want to follow up on what Lisa initiated around the discussion of the word patient. I've used that for most of my career, and I'm aware of that for most of my career. Many people, I guess this helps, many people who live with various conditions, and this is especially with people who live with longitudinal conditions, disabilities, they really reject the term patient because they're not it's a power dynamic you talk about. So all I'm doing with that is just raising the question to encourage people to think about that and see what other language you can come up with. One word that worked for people I've worked with was participant, but I'm not saying that's the answer. The question I have, though, is tied to that, and I think Lisa kind of ponied this up also. I've struggled through almost my entire career around working closely with advocacy and working within advocacy, but also not relying on them to speak for people with whatever that condition is. So how do you, advocacy brings a body of perspective and knowledge, but it has some holes. Individuals tend to speak of it and see it in the first person, it becomes awfully anecdotal. So how do you balance that in the work that you all do? I don't have an answer. I'm interested in how you sort that through.
It's a great question. Lisa, do you want to take it?
So with regard to the language that we use, it is very, very important. I typically say people, because that's what we are. And but I use patient when we're talking about the healthcare setting, and sometimes it's just the shorthand. So, but we do in our written documents we say people, people with CF. With regard to your question or comment about advocacy, it's true. We cannot claim that we know everything and speak for every facet of the population. And we always want to hear more experiences, and we reach out. We do our best to try to reach out and get feedback and perspectives from the folks that we typically don't engage with. So at the foundation, just by who we are, we reach a lot of people with the wherewithal to interact with us. And a lot of times that's not the people who need the help because they may be working 3 jobs or just don't have the extra time. And so how do we reach out to them? And one of the ways that we're doing that, or we're trying, is to reach out to them through their providers, because we know at least they're going to their docs, and perhaps the providers can be that conduit for us to reach. And so, but the thing about advocacy is where it's a lot of times, or sometimes it's the collective voice that has the greatest impact too. And so we just need to balance the two, and it's a constant challenge.
I would just add to what Lisa said. I'm also on the board of Mental Health America, which is the oldest mental health organization in the country, and was started by a mental health consumer. That's the word that's used in that community. And I view advocacy organizations in particular as a starting place. They're not an end point. It's just the same as what we're talking about today. There's no train station that you arrive at. It's a process and it's a cycle. And so I think the merit of advocacy organizations is a place to start and a place to coalesce and find that community. But the challenge for advocacy organizations is to not do 2 things: to not pretend that they're representing everybody, and to help all who seek information to find all the nodes, through social networks and other things. So I think that often advocacy communities are dismissed a little bit, especially in this town, as being institutionalized and overgeneralized. I would say that's a misrepresentation, and I would urge everybody in the audience to explore a little before you make that conclusion.
Yeah,
So,
I would also say, to the point about sort of anecdotal approaches, I think typically an ideal way, from my perspective, to understand what people, patients, consumers need is probably 4 different kinds of things. One is quantitative. It can often be very helpful, particularly at the outset, to start with quantitative data, survey data, understanding from a broad perspective, getting that. Focus groups can be very helpful in bringing people together to figure out when people begin a conversation, what's really resonating. But focus groups can also be a challenge because can be a certain amount of groupthink. People can get stuck on things. So a third piece of that is structured one-on-one interviews, which provides a really deep way of understanding individual needs, directly drilling down with a particular person. And then finally, direct observation. Observation in the clinical setting, observation in people's lives. Really is that ethnographic approach to understanding people's needs is incredibly valuable.
Could I just add something to
Yes,
that?
Susan, go.
Just to kind of speak to your point of the advocacy groups are very mature in the sense of they're very engaged, and we, in the work we do, often try to go to the kind of the grassroots community groups where these are individuals that are out in the community that are providing support to the patients that the individuals and the persons that aren't part of these organizations, these large national organizations, but have very much the same need. And I think that's where we see a lot less understanding of the meaning of their voice and moving value and healthcare forward. And we have found through our work in the community some key thought leaders, we call them our community leaders, that are able to then really get to those individuals with whom they interact. We've done outreach to Hispanic communities, and some of my colleagues are native Spanish speaking, and so these are community groups where they're organizations that are working with the folks in the community just to help them with basic life situations. And healthcare is a big part of that, of course. And so there are ways, in addition to the methods of collecting data through what Josh said, but there are also ways of thinking about who are your community leaders, and then who are the communities that you're engaging. And oftentimes we use them at both, we interact at both levels, not use like Paula. We interact at both levels because we do hear very different stories and try to get really the breadth of what that healthcare interaction is like across the board. So just to kind of, there are different ways of thinking about how you engage the individuals in the community.
Other questions? Lady in the polka dot or print, sorry.
Hi, I'm Sue Feltlisk from Mathematica. We recently did a focus group of patients from practices that had been trying to basically transform themselves to be more patient-centered, among other things. And I think it's important to educate providers as they try to become more patient-centered, not to view patient current preferences and goals as being an immovable object to which they need to defer. We had a couple of really good insights from the focus group where one case, it seemed that they had completely gone over to like, whatever you think, that's fine. And it resulted in a terrible situation for this caregiver who had said, it's kind of like really inconvenient for me to bring my daughter for post-operative care like all the way to wherever she had to go. Can't I just do it at home? And they're like, well, yeah, okay, you can try it at home. And it was a disaster, On the other hand, there was an example of one who was perfectly happy with her current medication regimen, but the long-term use of those medications was going to have a bad physical effect on her, and her doctor just kept working on her to the point where she realized that she needed to make a change. And so, yeah, I think it's just realizing that doctors need to continue to have the responsibility and do the work of trying to help move patients toward things that are good for them, as well as listening to them, obviously.
Dr. Steinhorn.
Well, I was going to say that decision-making for one's health isn't a single point in time. And that, as you said, there is a trajectory for most of us with most illnesses, whether they get better quickly or whether they're long, chronic, and incurable, and that people's values and decision-making changes over time, and that the healthcare system has to be responsive to those changes that occur. And that's something that we often don't do, checking in again with the patient or the family or the individual with the condition to see whether or not the decisions that they made 6 months ago or a year ago are still the same decisions that they're having now. Because as one's experience with illness or a medical condition that isn't getting better progresses, then one often comes to making other decisions for one's health and well-being and prioritizing what's really important. I perhaps don't want to try a third-line chemotherapy regimen. If this is not looking good, I just want to spend time with my family, with my loved ones, and accept the course of things. And along with this, I think that I'd be remiss in not mentioning that there's a very strong movement in the bioethical world to listening to the voice of children, which are typically lost. We listen to the voice of the parents because we believe that parents make decisions based on the so-called best interest principle for their children. Most of the time that's true. Sometimes it's not true. Remember that the parents are the ones who are they're not going through the surgery, they're not going through the chemo and the nausea, even though their hearts break when they see their children going through it. And we're not as good as a society and healthcare system in listening to the children's voices. And we've had many children, 8-year-olds, who say, I'm done, but I can't say I'm done because I know it would break my mother's heart, so I just have to keep doing this. So we're not really listening to the voices at that level. We're focusing on the socially acceptable agents, which are the parents in this case. I think that's an important thing because I believe there's no greater disparity in healthcare than being a child.
Great point. Let's take one more question before we wrap up. Shay?
Hey, Shay McCarthy from Thorn Run Partners. Jen, thank you for a great panel. I'm sorry, Lisa, you mentioned a point that I hear often from patient advocates, and that's this notion of token engagement or sometimes feeling like they're in a room sort of just to check a box, whether it's to satisfy the need of their grant requirements or something along those lines. I'm wondering what advice you have for patient advocates, whether they're patient advocacy groups or self-advocates, and that might be sort of unfamiliar with this process of academic research, to recognize the difference between when their voices are really being heard and when they're just in the room for token engagement, if you will.
I think Susan has some things to say on this too, but I mean, we all know what it feels like to be not used in a meeting. So I think that as much as what they can expect is that there are clear roles and responsibilities defined for their participation. And that could be different, you know, as I said, from participating in a survey or a focus group or an interview to participating in a clinical committee. It's very different, and it takes, for anything that we all do, it takes a different skill set. And so being upfront and clear about that, engaging in the conversations, asking questions, I mean, just normal things, because we all know what it feels like to be dismissed.
I can add to that our advisors, our individual level stakeholder advisors are consultants. They're paid to be on our research teams, just like we reimburse any other investigator on the team. So and they play a leadership role, and it's pretty clear that they're there for a leadership role. They're not there to be part of a focus group. They're there to help shape the questions that we're asking. So I think that it needs to be pretty clear that why they're there and what role that they're playing at the table, so that they're not just that token person. And I think that's where it becomes very important that we understand what the stakeholder engagement means. There's a wide range in how people will operationalize that. And I think bringing you to the table versus really engaging you in the discussion is a very important distinction between the two.
I would also just say that there's an infrastructure issue here from a broader policy-making perspective. We can't always, there's some situations when it's going to be just important to ensure that a patient voice is heard. In other cases, when there's something more clinical, technical, it is really important that there's sort of maybe some training or something, because it can be pretty overwhelming if you are a single, we'll call this person a patient for this purpose, in a room of 15 people that are all experts in health IT or quality measurement or whatever, and you're basically sort of a lone voice trying to express what really matters to the patient community in quality measurement or something of that nature.
Great. Final thought, Dr. Steinhorn?
Well, the voice of the patient. Who can't speak for themselves? I think this is a critical question to ask. It's the elderly with advanced dementia. It's the 42-year-old industrial steel worker who got traumatic brain injury from falling off a building and is in a coma. It's the 2-month-old with congenital heart disease that can't speak for themselves. I think that we have to keep this in mind in terms of trying to figure out as best we can what is the voice of the individual patient, and not simply the voice of their family or their loved one who is fearing the loss of their child or their parent or whatever it may be. I think that the statistics on the number of physicians who have advanced directives filled out, it's actually fairly small. And so I think that we can best advocate for ourselves and represent our own voices by these sort of mechanisms.
Great. Well, I think I can say that we've covered the gamut of whether patient involvement and the patient voice is important. And I think we've also unpacked a little bit of the complexity of how to implement it in the real world, thinking both in terms of the research and the clinical side of things. So thanks very much to all of our panelists for a thoughtful conversation. And I believe I'm releasing everybody to a coffee break. So thanks very much for your attention, and look forward to the rest of the day. Thank you.